Okay, so on to synovial joints and accessory structures. And this is not a specific synovial joint, it is just a typical synovial joint. So first, I just wanted to let you know that for the rest of the discussion, you can think that usually ligaments are closer to the two bones that are being connected to each other, whereas when we speak about tendons, which are connecting muscles to bones, the tendons are usually more superficial, more towards the skin than the ligaments are. And here's a nice picture of the elbow showing some deep ligaments, like the ulnar collateral ligament is shown here in this picture. But on the outside, superficial to that is shown the tricep tendon and the bicep tendon, just to give you a sense of where all this stuff is in three-dimensional space. Okay, so synovial joints, they're the joints with the greatest range of motion, the least stability. They're freely mobile within the limits of their structures. The stability and the range of motion of these joints may be increased or decreased by several factors. And these factors include the shapes of the articulating bones. So think of the shape of the humerus and the ulna where they go together. The humerus has an olecranon fossa. The ulna has an olecranon, and they fit together, perfectly for extension. And then in the anterior of the humerus is the coronoid fossa, and that space on the humerus is the perfect spot for the coronoid process on the ulna to fit into when the elbow joint is flexed. Okay, so that's an example of the shapes of the articulating bones having something to do with the way the joint works. And how the elbow joint works is as a hinge joint. It simply flexes and extends. Okay, that's just a hinge joint. Okay, and what it can do is determined by the shapes of the articulating bones. Of course, the radius is over to the side and it is articulating with the humerus also, but in less of a constricting way. Okay, then there are the collagen fibers in the joint capsule, and as we learned with the interosseous membranes, they can be shorter or longer, giving them greater strength or greater mobility. There can be different amounts of tensions in the tendons attached to the bones. Some muscles have more flexibility and other muscles have less, In addition, there are accessory ligaments in synovial joints, bursae, and fat pads, and we'll learn about those under accessory structures. So first, the synovial joint components, there are the epiphyses, which are covered with hyaline cartilage. Then there's a fibrous, dense connective tissue joint capsule around the joint. And I often think of this as almost like there was like a sock, that has the toe cut off around the joint. Okay, it's like a capsule that surrounds the bones. Then lining the joint capsule is a synovial membrane, and the synovial membrane secretes lubricating synovial fluid. The synovial membrane does not cover the cartilage. Just put that in your mind, okay? A little factoid. And there's a little space, a little joint cavity that contains the synovial fluid that's made by the synovial membrane. Okay, now accessory structures. Ligaments outside the joint capsule can reinforce the joint capsule. Ligaments inside the joint capsule sometimes exist. We'll find out about ligaments that are inside the knee joint in a moment. There can be menisci, which are pads of fibrous cartilage found in joints. There can be bursae, which are little sacs made of connective tissue, like forms the wall of the sac, and then inside the sac is a synovial fluid, and they act as little balloons of synovial fluid that cushion different elements of joints and separate different elements of joints and different elements of parts of the body that aren't even joints, like it can separate a joint from muscles or separate a bone from overlying skin. So they're just, there's little balloons of synovial fluid that act like little cushions. And then fat pads, which are made of fat, of course. So there are three different kinds of ligaments that can reinforce the joint capsule. The ligaments are continuous with the periosteum of the bones that are part of the joints, and they are classified as either capsular ligaments that are described as a thickening of the joint capsule itself, I suppose more tightly opposed to it so that you You almost can't separate it from the joint capsule. Then extracapsular ligaments, ligaments that are clearly outside of the capsule, and then intracapsular ligaments that are inside the capsule. Here are some menisci in the knees, the knee joints, and as I said, they're pads of fibrous cartilage inside the synovial cavity. They change the shape of the articular surfaces, helping to stabilize the joint. So here we have the knee joint showing the femur and the tibia, and we have a lateral meniscus and a medial meniscus that are cupping the condyles of the femur and preventing medial and lateral slipping of the condyles of the femur, either medially or laterally or anteriorly or posteriorly. They're like horseshoe shaped, the menisci. The cups are kind of horseshoe shaped. So, they prevent movement in all those directions, helping to stabilize the knee there. Okay. Then bursae, there are some bursae in the shoulder joint, and they're shown over here in this picture. There they are, reducing friction between different parts of the shoulder joint, which is such a tight shoulder, has so many elements, all in such a tight space. They're also found in the knee. Okay, fat pads, they are found at the periphery of a joint. They are lightly covered with synovial membrane. They are part of the packing material for the joint. They fill in the spaces in the joint cavity that are created as the joint changes shape as the bones move in relation to each other. And fat pads can protect articular cartilage also. I put in a new element. Oh, you want to see? So there it is. So as well as the multiple choice questions, I also put in a table here that you can fill out, okay, at this point and see if that's good. All right, moving on to the shoulder complex and shoulder joint. So it's the shoulder complex and not just the shoulder joint, because the shoulder complex includes the clavicles as well as the scapulae and the humeruses and the joints. Okay, so if it was just the scapula and the humeruses forming the glenohumeral joint, then it would just be the shoulder joint. But we're adding in the sternoclavicular joint into the mix. So the sternoclavicular joint, the humble little sternoclavicular joint, is called the master joint of the shoulder complex because as we talked about when we were talking about the pectoral girdle, there is only one place that the pectoral girdle actually articulates bone to bone with the axial skeleton, and that is at the sternoclavicular joint. So this right here, and you know how small your clavicles are at the end, that clavicle leads to the scapula, where it's joined at the acromioclavicular joint, and it forms the pectoral girdle, and then articulating with the scapula is the humerus. So the sternoclavicular joint is really important as the only point of contact with the axial skeleton. All right, so the sternoclavicular joint, it has a capsule that provides stability and limits movement. It has anterior and posterior sternoclavicular ligaments that reinforce the capsule. Then there's an interclavicular ligament that connects the two clavicles, and this prevents inferior dislocation of the clavicles when the shoulders are depressed. All right, so think of carrying big, huge, heavy buckets of water, and there's going to be a lot of strain on the shoulder joint, and then that strain is going to be transmitted through the scapula to where they're attached to the clavicles, and the clavicles are going to get pulled down, and you don't want the clavicles slipping off the sternum. You want everything to be nice and sturdy. So there's this interclavicular ligament. There are also two costoclavicular ligaments that are found between the clavicles and the first rib on both sides, although they're not shown on both sides in the picture. And the costoclavicular ligaments bind the clavicles to the first rib, holding them down. So the clavicles can also not slide superiorly off of the sternum in the other direction. So now, instead of imagining carrying buckets of water, think if you were hanging from a tree branch. We come from primates, of course, which, have a long history of, climbing in trees and that sort of thing. Well, there you are, you're hanging down. You do not want the weight of your body so heavy on your shoulder joint transmitted through your clavicles and pulling your clavicles superiorly away from your sternum. So there are those costoclavicular ligaments. Okay, what can the sternoclavicular joint do? It can glide, which means they kind of slip against, well, the two bones can slip against each other. The sternoclavicular joint can also slightly rotate and also circumduct or go around in a circle a little bit. All right. And why can the sternoclavicular joint do all this? Because it helps in determining the position of the scapula, which helps to determine the position of the shoulder joint, which helps to determine the position of the whole upper limb. So it's important that, as well as the sternoclavicular joint having a lot of stability, that it also have some range of motion. Okay, so as I've been saying, on its lateral end, the clavicle articulates with the scapula at the acromioclavicular joint. Sometimes this joint can separate, and then it's called when the glenohumeral joint like separates, it's called a dislocation. But when the acromioclavicular ligament separates, it's called a shoulder separation. But do not be confused. It is not a shoulder joint separation, because the shoulder joint is the glenohumeral joint between the scapula and the humerus, all right? And now we're talking about the joint between the clavicle and the scapula, all right? So completely different. Okay, there is a coracoclavicular ligament that limits movement between the clavicle and the coracoid process of the scapula. This, however, is not considered a joint in the sense of the acromioclavicular joint, all right? It's just ligaments found between two bones that are stabilizing them without it being the major point at which the two bones are bound together. Okay, so here we have our actual shoulder joint or glenohumeral joint. And we have the glenoid cavity on the scapula, and we have the head of the humerus right next to each other in a loose ball and socket joint. And this joint has the greatest range of motion of any joint in the body and the least stability. It's easily injured. People get shoulder injuries all the time. They get them whether they play sports or whether they don't. They just get them from getting older. They're just common. Okay. All right. The shoulder joint is the most commonly dislocated joint in the body. So now I'm using the word dislocation and not separation. Okay. So you might, say that it's a shoulder dislocation or a shoulder joint dislocation, right? The glenoid cavity has a ring of dense irregular connective tissue that surrounds it and helps to deepen it while at the same time not restricting its mobility unduly. So it offers support without restriction. The supraglenoid tubercle is superior to the glenoid cavity, and that is the part of the bone that the long head of the bicep brachii is attached to. But the labrum is also part of the attachment site for the long head of the bicep brachii. And as I mentioned in class, sometimes you can have a kind of injury where the long head of the bicep brachii is overused, like in sports, pitchers in baseball can get this, and it causes a tear of the labrum. Okay, so now beyond the labrum is the articular capsule. It's sort of oversized and baggy. It's a little tighter superiorly and looser anteriorly and inferiorly to give us some mobility. We want to be able to reach forward. We want to be able to lift our arms over our head because, again, we come from primates that did a lot of tree climbing, but we don't want to have our humerus hanging off of our scapula. So there's a little more tightness of the joint capsule superiorly. Then these are pictures of extracapsular ligaments that reinforce the underlying joint capsule, the superior, middle, inferior, and viral glenohumeral ligaments. I call these extracapsular. Let me just call them capsular, all right, because they're localized thickenings of the anterior joint capsule. All right, and there they are, stabilizing the glenohumeral joint. There is a coracohumeral ligament that helps to support the weight of the humerus. Here it is. I'm putting my arrowhead over it here. There is a coracoacromial ligament that's actually between two parts of the scapula itself. So not even between two bones, but between two bone processes on this scapula. And it provides some support for the joint capsule underneath. Then there's the transverse humeral ligament that holds down the tendon of the long head of the bicep brachii, which is in the intertubercular sulcus or groove between the lateral greater tubercle and the more medial lesser tubercle. Then there are names for these different bursae that are found in the shoulder, and here they are. The subacromial bursa is inferior to the acromion, and it is preventing contact between the acromion and the joint capsule. The subdeltoid bursa would be underneath the deltoid muscle. That is like a cap over our superior humerus area, and it prevents contact between the deltoid muscle and the joint capsule. So we had something preventing contact between bone and the joint capsule with the subacromial bursa. Now with the subdeltoid bursa, we have something preventing contact between the deltoid muscle and the capsule. So we see that bursae could be preventing contact and cushioning more than one type of tissue. Okay. Then there's the subcoracoid bursa that prevents contact between the coracoid process and the capsule, and the subscapular bursa that prevents contact between the subscapularis muscle and the capsule. Okay, and as I mentioned, just because it says subscapular doesn't mean that it's below the scapula. It's actually referring to being deep to the subscapularis muscle, which we'll learn in muscles. Okay, and here's the picture made bigger. Okay, and after we went through all of that trouble, because we're learning bones right now, we find out that actually the thing that stabilizes the shoulder joint more than the joint capsule or the ligaments is the muscles that surround the shoulder joint. And there are many of them, and we will learn them in great detail. There are all of the muscles that are found in these pictures. Left side is a superficial dissection, and the right side is a deep dissection. The top panel is the anterior view, and the bottom panel is the posterior view. And for now, we're not going to learn the muscles, but you can read through and see that there are many muscles that are surrounding and stabilizing the shoulder joint. These muscles and their tendons are often injured due to the high range of motion and low stability of the shoulder joint. Yep. So just like the ligaments of the shoulder, which can be injured, the bursa of the shoulder can be injured, the tendons of the muscles around the shoulder can be injured by the extreme range of motion and lack of stability and very tight spaces in the shoulder area. Okay, the knee joint. So the knee joint is composed of two joints within one large, incomplete joint capsule. There's a joint between the femur and the tibia, and there's a joint between the femur and the patella. The tibiofemoral joint is a hinge joint that can flex and extend and also can rotate laterally and medially just slightly, not very much. The joint capsule, ligaments, and tendons that are associated with the knee support the knee joint. There are fat pads within the capsule that help reduce friction between the femur and the patella. You can see it over here. Here's a little bit of the patella. Here's the femur, and you can see the fat pad would be reducing friction there. Okay, the knee joint is supported by 7 major ligaments. Of these, 4 are extracapsular and 2 are intracapsular. The first one is the quadricep tendon and patellar ligament complex. The tendon and the ligament support the anterior surface of the knee joint where there is no continuous joint capsule. And now for the 4 extracapsular ligaments, they are the medial or tibial collateral ligament. This ligament supports the medial knee joint. Then the lateral or fibular collateral ligament. This ligament supports the lateral knee joint. Then there are 2 popliteal ligaments that support the posterior knee joint. There are 2 intracapsular ligaments. They are the anterior cruciate ligament and the posterior cruciate ligament. The anterior cruciate ligament originates on the anterior of the tibia and travels posteriorly and inserts on the posterior femur. It limits anterior movement of the tibia and twisting of the knee. The posterior cruciate ligament is found posteriorly on the tibia and anteriorly on the femur because it travels from the posterior to the anterior. It limits posterior movement of the tibia and twisting of the knee. In order to learn this easily, I find it easier to think of the position of the ligaments on the femur. So the anterior cruciate ligament actually starts posteriorly on the femur and it limits anterior movement of the tibia. The posterior cruciate ligament is found anteriorly on the femur and it limits posterior movement of the tibia. And hopefully that makes it easier for you to understand what these two ligaments are doing. All right, then.